Alright, this is Horry County Fire Rescue's 2014 Annual Bloodborne Pathogens Update. We have chosen to do a webinar update this year, so we'll tell you at the end of the program how to go about asking us questions. So, we're going to start with our first slide that explains the Bloodborne Pathogens OSHA mandate, which is 1910.1030. There are some objectives for this, for OSHA's annual training. They do say that we have to meet some objectives, which is give you some updated information on diseases that we already know about and some new ones that have arisen, to explain some different training responsibilities that have come about. We have to talk about some compliance issues that we as a department have, some updated information on proper use of PPE, especially when it comes to face masks. We're going to talk a little bit about declination forms, which there's two main points that comes into play, and we're going to talk about the different flu vaccines that are available out there. Throughout this presentation, you'll see two different color slides. This color green as the background is information that we already know, and whenever you see a slide with pink as the background, that's going to be new and updated information, and those slides are labeled appropriately. So we're going to start out with what is bloodborne pathogens, and that is different viruses, bacteria, and microorganisms. We all know that these are ones that do cause disease, and that generally they are transmitted by ways of the bloodstream or by other potentially infectious materials, which we'll get to a little bit later as well. There are several different types of bloodborne pathogens. The three that we have heard about the most are HIV, hepatitis B, and hepatitis C, and generally those are the ones that cause the most concern for occupational exposures. These numbers here are for 2012 and 2013 nationwide. These numbers I did get right from Catherine West when we went to her annual bloodborne pathogens update last month. Earlier this month. So these are new cases nationwide for 2012 and 2013. So if you look at the 2013 statistics, especially down where it says measles, mumps, and rubella, new cases, mumps cases for 2013, 438. So on a nationwide basis, this is not a huge number, but when we're looking at cases of measles, mumps, and rubella coming back when we had eradicated these because of vaccines that we have, this is huge. So some outbreaks have arisen because of this, and you'll also see at the very bottom pertussis or whooping cough, 24,321 cases nationwide, and that's huge as well. It causes very big problems for certain populations, and we'll get to that a little bit later as well. These are disease numbers for South Carolina. For 2013, I got these straight from South Carolina DHEC, and these are new cases. So HIV in South Carolina, we've had 456 new cases. Hepatitis B, we've had 495, and of those, there's the breakdown between acute and chronic. Hepatitis C, we have 3,246 new cases. And when you look at the breakdown there, you see that all of those are chronic cases of Hep C. Syphilis, 750 new cases, and tuberculosis, we were looking at 112 new cases. Specifically of those, 5 were in Horry County. There is a change in terminology. We have seen the abbreviation HAIs, and that generally stood for hospital-acquired infections. That's where we saw some of our drug-resistant organisms come from. They were based out of hospitals being spread between the staff and the patients. Now they have changed that terminology to healthcare-associated infections. So what that means for us is that we are a healthcare agency. So we are covered under this term now. So insurance agencies, the CDC, places like that are now looking at EMS. They are now looking at nursing homes, dialysis centers, different types of healthcare organizations as causes for these infections that patients have acquired. So what does that mean? It means that right now, We are not seeing a huge change as far as insurance agencies on the EMS side, but in the very near future we may see that insurance agencies may not reimburse like they do in hospitals if they can prove that EMS was the source of the patient receiving that infection. So this is just something that we need to be aware of right now and just know that changes may occur in the future. I put this in here as well. Our compliance officer, Tony Flaherty, has asked me to put these in. So this is straight from OSHA, what they define a contamination as and what they define an exposure as. So contaminated is the presence or the reasonably anticipated presence of blood or other potentially infectious materials on an item or surface. So other potentially infectious materials, generally any body fluid that escapes someone's body, especially that has the presence of blood in it. So a contamination, it's on an item or a surface. So there's dry blood on a table, or there's someone's blood on your intact skin. An exposure incident is a specific eye, mouth, or other mucous membrane, non-intact skin, so it gets in an open cut that you have, or a parenteral route like a needle stick. It's not going through the GI tract, it's coming in through another route of the body, and that is contact with blood or other potentially infectious materials that results from the performance of an employee's duties. So an occupational exposure. So there is a big difference between the two. Exposures, we report, we go through testing. Contaminations you do need to be aware of, you do need to make the appropriate personnel aware of, but generally there is not testing that comes with that, post-exposure testing, because it's not a true exposure. Transmission-based precautions, there are several different levels of PPE that we can take when we're looking at different conditions. So our universal precautions are the same that we use with every patient. We need our safety glasses, we need our gloves. When we're looking at diseases that are caused by contact precautions, whether direct or indirect, so direct is we're directly coming in contact with it. Indirect is we're coming in contact with it throughout a different source, like blood on an object that we now come in contact with. So when we're looking at contact precautions, we can look at gowns, definitely masks, and our same gloves and safety glasses that we use. So we'll take an additional level of PPE. With droplet and airborne, generally, in addition to your universal precautions, you're looking at a well-fitting mask to protect yourself, and we'll talk a little bit more about masks in a few minutes. These are our exposure numbers from Captain Flaherty for all of Horry County Fire Rescue in 2013. So we had a total of 18 exposures. Of those, 3 were bloodborne, 1 by needle stick and 2 by broken glass. 14 were in the other category. Some of those were different forms of meningitis that employees were exposed to, and we have had 1 airborne exposure, and that the source patient did have tuberculosis. There is some information on the Ryan White Act. There is some updated information as far as the list of reportable communicable diseases, and I'll show you those on the next few slides. There also are some changes to vaccine and immunization recommendations and responsibilities. So the list of reportable communicable diseases, bloodborne, generally ones that we have heard of, HIV, Hep B, Hep C, but some others that you may not have seen or heard of in a while. The last 4 bullets there, rabies is on there, cutaneous anthrax is on there, so some different ones that we have not heard of in a little while as well. Airborne communicable diseases, measles is on there, which we definitely have seen outbreaks of those nationwide. Chickenpox is on there, and tuberculosis is on there. So those are all transmitted by the airborne route. The reportable diseases that are transmitted by the droplet route, those are all listed there. Meningitis that we have known of, diphtheria, mumps, pertussis, all of those. The bottom one there, influenza A viruses, novel being the key word, and those are new and different viruses. So when H1N1 came out, that was a novel virus that we had to have reportable conditions for. Recommended immunizations and vaccinations, these are what are recommended by the CDC. Hepatitis B vaccine is recommended especially for all healthcare personnel. Tdap booster, one booster shot following your series through your childhood vaccinations, and we'll get to that a little bit later. There is a chickenpox vaccine. The MMR is recommended, seasonal flu vaccine is recommended, and then we'll talk about TB testing recommendations as well, because some of those has changed. So these are all what's recommended by the CDC. NFPA does say, if you look at the quote here on the right side of the page, that they shall be provided as indicated. So NFPA does support these as well. This slide here is more for your information. This slide gives you information straight from the CDC of why they recommend each vaccine for healthcare workers. So if you wanted to know why an MMR was recommended, you can read it right here on the table why the CDC recommends these. And all of the links where I got the information is located at the bottom of the page, so you can always follow those links as well. So let's get to some updated information. The shingles vaccine, there have been some questions about that as well. The vaccine is pictured there on the screen. This is generally a one-time vaccine, and it's recommended for people 60 years of age and older. The CDC says, the bullet there in pink, that there is currently no recommendation for routine use in people ages 50 to 59 years old. So this is generally a 60 years of age and older vaccine, and it's not something that they recommend to treat an active case of shingles. Pertussis or whooping cough, this is something that we've heard about, we've talked about, but we want to bring this back to the table and shed a little bit more light on this. This is one that's caused by droplet, and it is something that's highly contagious. So if you have had a baby recently, your pediatrician may have talked to you about getting a Tdap shot, which we'll get to that in a few minutes, but that is a vaccine that protects against pertussis as well. So again, highly contagious, face-to-face contact, generally within 3 feet of the person who has it. The third bullet there is really important. It can cause life-threatening complications, especially in young children and definitely in infants, and we'll get to that on the next slide. Some signs and symptoms are listed there. It usually takes about a week to a week and a half to start seeing some of those signs and symptoms. We do have prevention for it with a Tdap shot. Children have the same shot. You'll see it called a DTaP, and it's just the pediatric version. So if you are transporting a patient who has pertussis, it is appropriate to place a surgical mask on the patient. If they cannot tolerate a surgical mask, they need oxygen, whatever the case, it is absolutely appropriate to put a surgical mask on yourself for protection. And post-exposure, generally pertussis is treated with antibiotics. So complications of it, if you look at the infant side of this slide, they have some very significant complications that result because of this. And some statistics there. Sorry, it was a little hard for me to say that word. How many infants will get pneumonia as a result, how many patients will seize as a result, have apnea, encephalopathy, the percentage that will die. And some of these, it doesn't look like large percentages, but when infants are affected and they don't have all of the immune buildup that we have and the antibodies that we have, it's really hard for them to fight significant diseases such as these. So although those numbers, some of them look like small percentages, they're very significant to the families who are facing these statistics. If you look to the right side for teens and adults, some complications there. A lot of the complications are caused by the coughing fits that come with this, including fractured ribs. Some are hospitalized, some get pneumonia, and if you look at the bottom there, again, most of them caused by coughing, syncope as a result, weight loss, and loss of bladder control as well. So some updated information on pertussis. Most of the infants who contract whooping cough get it from older siblings, parents, daycare workers, whoever is caring for that person or that patient in close proximity of them. Unfortunately, some of these individuals don't know that they have it and they are passing it on to these infants. This is brand new information, this next bullet. I'm going to read this word for word for you. The CD says from January 1st to April 14th, 2014, so just the beginning part of this year, the first quarter of this year, almost 5,000 cases of pertussis has been reported to the CDC. That's a 24% increase compared to where we were last year. So this is huge. This is a huge outbreak that we're seeing of pertussis cases in this country. Unfortunately, many of these cases are preventable with appropriate vaccinations. So it is important to stay up to date with these vaccines and to stay up to date with childhood vaccines. So some more updated information about the Tdap vaccine. So Tdap, again, is the adult version of this vaccine. DTaP is the pediatric version. So for adults, for those of us who have had our appropriate childhood vaccines, the CDC does recommend a booster vaccine for adults ages 19 to 64. So a one-time follow-up booster shot to help us ensure that we still have the immunity and the antibodies built. So they are recommended especially for certain populations, which healthcare providers are there, but it's generally anyone who has the potential to be in contact with children, treating them medically or on a daily basis, such as parents, grandparents, and child care workers. We have some updated information on the MMR vaccine as well. People who have received their initial MMR vaccine between the years of 1963 to 1967, the CDC does recommend that you are revaccinated, and that is a 2-dose vaccine. Generally, they're given about 1 month apart, and that is because the vaccine that was given during that time period was not effective. So if you received it during that time period, there is a chance that you do not have immunity to, you did not build antibodies with this MMR vaccine. On a new hire level, if a new employee comes to the organization and they are unsure of their measles status, they're unsure if they've ever gotten this vaccine, it's not necessary to draw a titer. The CDC recommends that you just go ahead and revaccinate. For companies, this ends up being cheaper in the long run as well. So some refresher information on HIV. We do know that this is the virus that leads to AIDS. Since they started reporting these cases, there have been 57 healthcare workers who had an occupational exposure to HIV and who ended up contracting it. So some additional information to that number of 57, 0 were fire EMS, 49 were sharps related. And the next bullet there, the CDC says that of the 57 people, 90% of them had some outside work risk factors for acquiring this infection. So incubation period is listed there, 1 to 3 months. HIV and AIDS are still diseases that do not have cures for them, but there are some advances in medications. We also do not have any vaccines available for this. So routes of transmission are listed there. Risk of needle stick risk of transmission is listed below. Needle stick risk of transmission is 0.3%. Mucous membranes 0.09%. So very rare to contract this occupationally, which is a good thing. The biggest risks of contracting this, especially occupationally, is deep needle stick injury, generally a significant amount of blood or enough blood that has over 1,500 circulating virus per milliliter of blood. So it's generally someone with end-stage AIDS or early on where they have viral loads big enough that they can transmit this. And we'll define this a little bit further on the next slide. Since 1999, we have had nationwide 0 occupational exposures of HIV. One big change now in our terminology for HIV is that we now consider this a chronic disease. So instead of this being a death sentence within the next few years, patients who have HIV and AIDS, if you look at the third bullet there, they're living up to 50 years longer post-diagnosis. So this truly has become a chronic disease because of the advances in medication. So the fourth bullet there is an AIDS cocktail of drugs that patients are taking, and you can see the AIDS cocktail down there at the bottom of the page. But of the patients who are taking this cocktail successfully, 96% of them are responding to it, and they are unable to transmit HIV or AIDS. So if you had a patient who had HIV or AIDS, you sustained a needle stick from them, and they were responding to this AIDS cocktail, there's a good chance that they aren't even able to transmit this disease. There are some changes to post-exposure testing, changes that deal with if the patient is negative for HIV and if the patient is positive for HIV, and you can see these here. There are rapid HIV tests as well, and those are listed at the bottom, but this is information for post-exposure testing. If you would like to see, there's more information at the link below, but generally what the employee will go through. Initially, at the top of the page, if the patient is HIV negative, there's no further testing needed for the employee as far as a follow-up status of HIV, because the patient is negative, they can't transmit this to anyone else. So a change to this is that they're doing this rapid testing initially, and if it shows up negative, it's saving employees from going on all kinds of toxic medications and making them really sick, even if it is for just a short amount of time. Changes to patients being HIV positive. They have their baseline testing. The employee will do a 6-week post-exposure testing, and at 4 months post-exposure, they'll do a rapid HIV test. So that is a change to the positive post-exposure testing. Hepatitis B, some refresher information. We all know that this is the virus that causes hepatitis B. Incubation period is listed there. We do have a vaccine for this, and if you look at the middle of the page, 50 to 60% of the people who have hepatitis B do not know that they have it. So reporting an exposure is definitely important. Even if you got a history, a bloodborne history, and the patient said that they didn't have it, half of them, or greater than half, don't know that they do. Routes of transmission are listed there. Risk of needle stick, you'll see the biggest risk for hepatitis B. So 6 to 30% chance risk of contracting hepatitis B occupationally with needle stick injuries. So that's huge, and find comfort in the fact that we do have vaccines against this. And hepatitis B is another one that can be a little bit sneaky as well, because this is one that we can get by indirect contact with dried blood on a surface. So hepatitis B can live in dried blood for several days on surfaces. So it's very important to be aware of that, especially when you're cleaning your equipment and deconning the trucks. The vaccine effectiveness, 90% of the people who complete the 3-dose series as recommended by the CDC build immunity to it. So in the first dose, you get about 30% to 55% protection from Hep B. In the second dose, you're looking at about 75%. And in the third dose, when you complete the series successfully, you have greater than 90% protection from the hepatitis B vaccine. Or I'm sorry, from the virus itself by receiving the full vaccine. So it is important that you do the full 3-shot series. This started in 1983, and since then we have seen a huge reduction, 95% reduction in the number of healthcare workers who contracted hepatitis B occupationally. So some updated information about it. The first bullet here is brand new information. There are new requirements set by the CDC saying that they recommend that all trainees, all new individuals who are coming on board have all 3 doses of the hepatitis B vaccine before being placed at risk. So before going out on clinicals, it is recommended, or before going into patient contact, it is recommended that they have all 3 doses of the hepatitis B vaccine completed. And in the middle of the screen there, you'll see in quotations, word for word, what the CDC website says about those recommendations. So as far as a new hire standpoint, if someone is coming on the department and they cannot provide documentation of their immunity, it's okay to go ahead and restart the 3-shot series. And the only time a titer is drawn is 1 to 2 months after the completion of a Hep B vaccine. So if they come on board and they're not sure if they've ever had the vaccine, just go ahead and give the 3-shot series. Don't titer first and go from there. The only time to titer is after the Hep B vaccine is completed. Hepatitis C, some refresher information here. The virus that causes hepatitis C, incubation period of about 6 to 9 weeks. 70 to 85% of the people who get this infection see chronic infections. They see lifelong complications as a result of it. There are symptoms listed there, and at the bottom, 80% of people who have hepatitis C do not have typical signs or symptoms, and they may not know that they have it. So there's more people out there with hepatitis C who don't know that they have it than there are hepatitis B. So again, I stress the importance of reporting and exposure. Routes of transmission are listed there. Risks are listed below. So a needle stick from someone who is hepatitis C positive, there's a 1.8% chance that healthcare workers will contract the disease, and mucous membranes, it's very rare. Some updated information about it, that we have seen some increases in the rates of healthcare workers who are contracting hepatitis C. And the biggest reason for this, which you'll see in bold at the bottom, is that people are not being compliant with infection control practices. Over 150,000 people were called back for HIV, Hep B, and Hep C testing because of a break in the infection control practices. And there are some places who have seen outbreaks in particular, like those listed there in black, ambulatory care clinics, different forms of dental practices or free dental clinics, dialysis centers. So unfortunately, these places have seen increases in the numbers of Hep C because they're not maintaining regular infection control practices. The CDC also has some recommendations for people who were born between 1945 and 1965. The CDC recommends that they do have a hepatitis C rapid test done. There are some rapid tests that I've listed there in the middle of the page, and some additional information towards the bottom. So positive rapid testing, if you look at the bottom of the slide there, doesn't mean the person is currently infected with Hep C. So if they have a positive rapid test, they're going to do a follow-up with a blood test to confirm results. So in the event of an exposure, especially if the patient is hepatitis C positive, there are blood tests to be done. The blood test is listed there. If the post-exposure testing shows that an employee is Hep C positive, there are treatment options for them. We do not have a vaccine against Hep C. Some of our treatments have changed. There are some new drug treatments out there. There's the 2 that are listed below. And if you read the bullets under each of them, some patients have been cured. 75 to 79% of patients were cured from Hep C in 24 weeks of that treatment. Both drugs there are FDA approved, and patients have seen some great results with their Hep C outcome, and a large percentage of people have been cured of Hep C as a result of taking these. There are some newer drugs out there on the market as well. One in particular, which is listed at the bottom, which I'm not even going to try to pronounce. If you look at that, the cost is about $1,000 per pill, and they take 1 pill a day. And this is a treatment time frame of about 12 to 24 weeks. So when you look at the overall cost of taking this medication for someone who is Hep C positive and is being treated for it, the medication alone is going to cost them about $84,000 to $168,000. But when you look at doing that route of treatment as opposed to being treated for liver failure and going through a liver transplant, and being put on a waiting list and taking post-transplant medications, the benefits may outweigh the risks. So, and it may be cheaper in the long run to take the medications as opposed to going through all of the post-exposure treatment and liver transplant. Syphilis, we bring back to the table again, some refresher information that we already know. Generally, we know syphilis as being a sexually transmitted disease, but this is also one that can be transmitted by bloodborne. So we do talk about it in Bloodborne as well. There are some signs and symptoms listed there, and generally treatment involves antibiotics. This is a part of point-of-care testing, which we'll talk about in just a few minutes as well. So some updated information about syphilis. The CDC gives us some updated information on testing guidelines for STDs. The link that I got that information from is listed there. There are some groups at risk listed there in the center of the page. And the CDC has a plan to eliminate syphilis from the United States. They had a goal of 2015, but as you saw on earlier slides with the increases in the numbers and the new cases that we saw nationwide, it does not look like we will meet the goal for 2015, but the CDC still has a plan to eliminate it from the United States. So in 2013, the four states that had the highest cases of new syphilis: California, Texas, New York City specifically, and Florida. So point-of-care testing, which I mentioned a minute ago, is becoming the current standard of care for practice in hospitals and in some EMS agencies. It can be performed at the bedside. One example of this that you see with point-of-care testing is the glucometers in the hospital. So this is kind of just taken to a different level. So point-of-care testing, here is the definition given. It's laboratory testing that takes place at or near the site where the patient is located. So it's easily done at the bedside. You don't have to send it to the lab. You don't have to wait an extensive amount of time for results. So point-of-care testing, it's able to test for several different diseases with a small amount of blood, and you get results in minutes. So there are several diseases here that they test for. They're listed here. HIV and hepatitis C are on that list. Syphilis, which I mentioned just a minute ago, it does test different strains of flu and other diseases that are listed here as well. So revisiting tuberculosis, this is information that we're already aware of. It is a bacterial infection. It is spread by droplet. So protection, especially a mask, is important. The CDC does give some definitions as what we classify low-risk organizations and medium-risk organizations. So a low-risk organization is one that has transported less than 3 active TB cases in the last year. Medium risk is an organization that has transported more than 3 active TB cases in the last year. And this is transported. This is not responded to and a family member in the house had tuberculosis. This is actually transporting in your vehicle. So the cases are there. 2011, we saw 10,528 new cases in the United States. In 2012, looking at South Carolina, there were 122 new cases, 9 specifically in Horry County. In 2013, nationwide, 9,080 new cases that were reported in the U.S., and that we saw the lowest new case numbers since 1953. Of those in 2013, 79 were in South Carolina. So some signs and symptoms of TB are listed there as well. And for us, for protection against TB, the CDC says that if you are transporting a patient who has active TB, it is appropriate to put a surgical mask on the patient. Make sure you're using the exhaust system. You can open the windows. Make sure that the air is circulating. If the patient cannot tolerate a mask or they're wearing a non-rebreather, it is absolutely appropriate for you to wear a surgical mask to protect yourself. So Horry County Fire Rescue, what is our tuberculosis risk? In the year of 2013, we transported 1 patient who had active tuberculosis. So since we are below 3, we are considered low risk according to the CDC. So since we are a low risk department this year, we are not doing annual TB testing because we are placed at low risk. So some updated information about tuberculosis. There are 2 strains, those listed there in purple. Those are multi-drug resistant forms of tuberculosis. A lot of them we see in people who were born outside of the United States and who have come here. Although they are multi-drug resistant, both cases are treatable. There are new shorter courses of treatment that we are seeing for TB. The courses of treatment have been cut down to 12 weeks instead of 6 to 9 months. But with these new medications, it's very important to know that they are liver toxic. So no taking alcohol because it's processed in the liver. Trying to give your liver the most amount of rest possible while taking these medications is very important. There also has in recent years been a national shortage of the TB testing solution. So there are 2 blood tests that can be used to test TB. They are listed there in purple as well. They're both FDA approved. An average price range is given there as well. Both blood tests are accurate, and they can be used in the place of the TB test to test someone for active tuberculosis. So the blood tests can be used as a route of new hire testing, and in agencies that do annual testing, they can be used for that as well. This quote here with the source listed shows generally how easy it is, or for better words, how not easy it is to contract tuberculosis, and this quote here says it's not spread by casual contact. It's generally prolonged contact in a shared airspace. So even on long flights in a commercial aircraft, flights generally 8 hours or longer, with TB transmission, it's generally kept to passengers who are seated in close proximity to the patient. So not the whole aircraft is affected, it's generally the people who are sitting next to them that have the highest risk. So let's talk about flu shots for a minute. The CDC does have a flu vaccine program. They do recommend flu shots for all healthcare workers who are involved in direct patient contact. So they do say that employers do have to offer the flu shot, which we do, and employees who don't want to receive the flu shot need to sign a declination form. So keep this in mind in the coming months as we approach flu season. So in the hospitals, many hospitals now have mandated that their workers get flu shots. They have also said that if their employees do not get flu shots, they need to wear masks anytime they're on the hospital premises during flu season. So in EMS, we are not at that point yet, but there are studies that show that EMS participation is one of the lowest ranking groups nationwide as far as healthcare workers who have received flu shots. So on a department-wide level, in 2012, Horry County Fire Rescue gave 85 total flu shots. Of those 85, 22 were not employees or volunteers of Horry County Fire Rescue. So they were family members or they were people in other departments. So 63 employees in 2012, employees or volunteers, received the flu shot. In 2013, 83 flu shots were given, 24 were not employees or volunteers, so 62 total employees and volunteers got flu shots in 2013. So when you look at numbers in the 60s for a department approaching 350 personnel, those numbers look pretty grim. So some updated information about flu shots. There are actually 5 different flu shots that are available, and we're going to talk about each one of them. So the first one, the vaccine for 2013-2014, is the same form of a flu shot that we've seen every year. It's the trivalent, so it has 3 different strains in it. It has 2 A's and 1 B, and those are listed there. And that's the vaccine that we've seen and that you've probably gotten the last few years if you got a flu shot. The second one has been out within the last few years as well. That's a quadrivalent one. It's either the flu mist that's given intranasally, or It can be given as an injection as well. So with it being quadrivalent, it has 4 strains in there. It has 2 A's and 2 B's in there. This one is not a pediatric shot. It's not approved for children less than 6 years of age. There's also a vaccine for individuals over 65 years of age. It is a high-dose trivalent, so it has 3 strains in it, and it contains 4 times the amount of antigen in a regular flu shot. So for people over 65 years of age, they need the extra antigens in there for them to build antibodies. The 4th one is a cell-based flu vaccine. That's the picture that you see there at the right side of the page. This is not grown in hens' eggs. It's grown in cells rather than in eggs. So that has an advantage for individuals who are allergic to eggs. However, this is an adult shot. It's only for people 18 years of age and older. So there are some advantages to this. Again, it's not dependent on an egg supply, and individuals who have egg allergies can benefit from this. The cells that they are grown in are kept frozen and banked, so in the event of a pandemic, there is a faster startup to get this vaccine out there and manufacturing it. The 5th one is a new flu vaccine. It's called Flu Block. The picture is there on the right side of the page. This is for adults in the age range of 18 to 49. So it does have a specific age range there. Again, this one is not grown in chicken's eggs or hen's eggs. There are no antibiotics used in the manufacturing process, and there is no mercury used in the manufacturing process. It does have a similar manufacturing process as other vaccines that you see, but this one does have a shorter shelf life. This one, as well as the previous flu shot, it does have a faster startup manufacturing in the event of a pandemic. So the bottom bullet there, it has accommodations for people with several allergies, and those allergies are eggs, thimerosal, mercury, and antibiotics. So they can definitely benefit from these vaccines. There also has been research done that shows that there's an antibody called CH65, and this is an antibody that can recognize several different strains of a flu vaccine. 36 strains of H1N1 were tested, and this antibody was able to neutralize all but 6 of them. So this one is able to recognize a very good amount of influenza strains out there, and this is very helpful in creating vaccines because this could be a longer lasting vaccine. So this may be one that you would get every few years instead of every year. So there are new developments out there, and we'll continue to provide updated information as they bring this out. When we talk about flu season and appropriate PPE, the CDC does recommend that a surgical mask is used for patients who we suspect have the flu. The flu is transmitted by droplet precautions, so placing a surgical mask on the patient is appropriate. If they cannot tolerate this or they are wearing a non-rebreather, it is absolutely appropriate for you to protect yourself by wearing a surgical mask. When we look at updated information on prevention, you will see that surgical masks are what the CDC recommends for respiratory conditions. So all of the respiratory conditions that I've mentioned already, the CDC recommends a mask on either the patient or yourself for protection. They say that a surgical mask is appropriate to use in these cases. So above all, hand washing, which we have heard for forever, is still the best way to prevent the spread of disease. So I know it's not always the easiest to wash your hands when you're out there. We don't have sinks accessible to us 24/7, but as soon as you get to the hospital, as soon as you get to a place where you are able to wash your hands, please do so, because that is still the best way to prevent the spread of disease. Some additional updated information on prevention. Getting a travel history, we're going to see, is going to be essential, especially when we look at certain segments of the population who are presenting with certain signs and symptoms. So we're hearing about a bunch of new conditions that are out there that have been brought into our country from people who are coming from different countries. So getting a travel history, especially with someone with respiratory symptoms, is going to be essential. So let's talk about MERS for a minute, Middle Eastern Respiratory Syndrome. There's been a lot of hype about this. There's been a lot of talk about this. This is a condition that's caused by a coronavirus. It does affect the respiratory system, and it presents with signs and symptoms listed there in purple. It does have a 30% mortality rate for people who are affected, and generally the cases that we are seeing, all of them have been linked to countries in or near the Arabian Peninsula. The CDC says that MERS is a very low risk to the general public in the United States. Generally, it's spread between individuals who have close contact. So it's an individual who is caring for someone who is sick or living with someone who is sick. There has been no evidence so far of it being transmitted in a community setting. So it's not easily transmitted. It is important to get a travel history, and we're looking for key places like areas around the Arabian Peninsula. And a surgical mask on the patient or on yourself is appropriate for protection. So we've heard so much about it, but there's only been 2 cases in the United States that have been documented since May 2nd of this year. There was 1 case in Indiana and 1 case in Florida. The case in Indiana, it was a traveler confirmed that they came from Saudi Arabia. They were a healthcare worker who lives and works in Saudi Arabia. This person has since been discharged from the hospital and has fully recovered. The case in Florida, again, a confirmed traveler from Saudi Arabia. They were a healthcare worker as well, and they are currently isolated in a hospital but doing well. So we switch now to multi-drug resistant organisms. We're going to look at some updated information there. With C. diff and norovirus, we do know that we need to be using chlorine-based cleaning agents. We'll get to that in the next few slides. And hand washing with these organisms is very important. Alcohol-based products, hand sanitizers, hand wipes, things like that don't kill these. These are spores, so these need to be washed off with warm water and soap. So hand washing is best. Alcohol-based products are not effective when you're dealing with these organisms. There's a new multi-drug resistant organism out there called CRE. I'm not even going to try to pronounce the actual name for you guys. This one does have a high level of resistance to antibiotics. Generally, healthy people do not have to worry about contracting this. Unfortunately, the infections are difficult to treat, and CRE can have up to a 50% mortality rate. Patients who have this are placed on contact precautions, which means additional PPE. If you look at the picture there, definitely gowns, definitely gloves. Have your safety glasses on as well. So get a good health history. We're seeing CRE with people who are having indwelling devices, catheters, PICC lines, things like that, easy routes into the body, some septic patients as well, and a travel history. Have they been in an overseas hospital, especially within the last 6 months? So hand hygiene, again, hand washing is the most important way to stop the spread of diseases. And all of these here are bullet points of when you should wash your hands, which essentially, when you break it down, is many times throughout the day that you should be washing your hands. So all of them and then some are listed here. When we're looking at hand hygiene, it is important to pick appropriate means of washing your hands and temperature of water. So antimicrobial agents, antimicrobial soaps are best. They are better than antibacterial. So the CDC recommends that you use antimicrobial soaps and not antibacterial. If you look at the bottom there, the triclosan, they don't have the ability to kill gram-negative bacteria, so agents or soaps, anything like that that has triclosan in it is not recommended in the healthcare setting because it's not the level of hygiene that we need. When washing your hands, use warm water. They say not to use hot water. It can increase your risk of contact dermatitis and rashes and open wounds on your hand as a result of washing either too much or improperly. Again, the antimicrobial soap comes into play there. They do recommend that you use disposable towels like paper towels instead of using the same towel for everyone to dry their hands on. It is important that when washing your hands, you rub your hands together vigorously for at least 15 seconds. And again, which we've heard several times before, no artificial nails when working in healthcare. So, updated information about our work practice controls. You guys received this information a few weeks ago. All of our sharps containers are to be disposed of at Grand Strand Regional Medical Center. Put them inside the door of the tan shipping container there that's located on the dock side of the hospital at Grand Strand. So make sure you're sealing your containers with medical tape. Write the number SC26-0029G and HCFR on the tape. So make sure you're doing that. We are in the process of working with Conway Hospital to hopefully have them become a drop station for sharps containers as well, and we will update you guys with any changes. So speaking with Compliance Officer Captain Flaherty, there are some tidbits. Just make sure, again, you're washing your hands as soon as possible after a call, not just using hand wipes. Make sure that you're using appropriate decon techniques when deconning your apparatus, when deconning equipment, especially the equipment that's used on every call, stethoscopes, blood pressure cuffs, pulse ox. Your glucometers, keep them in mind as well when you're doing your decon process. Make sure backboards are being deconned appropriately as well. He also stressed inside the cab of the medic unit, make sure you are deconning there also to help prevent the spread of diseases. A reminder about hypochlorite solution. It is a 1:100 mix. You have to have a piece of tape on the bottle that the hypochlorite solution is in, and you have to write 1% hypochlorite solution. If you look at the words in bold at the bottom, there is no abbreviation for hypochlorite solution, so please make sure you write this out. Also on the piece of tape, you need to have the date it was mixed, which it needs to be made new every day. And you need to have the name of the person who mixed it. You also need to have an SDS sticker on the bottle, which you'll see there on the right side of the screen. That one was written out and marked appropriately, and in case you couldn't read it clearly, I did type above the sticker what you need to write for the chemical name, for the manufacturer's name, for the address, and for the emergency phone number. So please make sure these bottles are labeled appropriately. Also updated information from Captain Flaherty regarding post-exposure reporting. In the event of an exposure, you are to call Captain Tony Flaherty. His phone number is listed there, 843-446-6610. So he is who you are contacting now for exposures. When you call him, he will contact the infection control nurse, and then he will respond to the hospital where you are transporting your patient. When he gets there, he's going to complete the workman's comp S&E report and get all of the paperwork taken care of. So your post-exposure treatment, it depends on what you were exposed to, what the CDC recommends as far as post-exposure follow-up. So it's going to be different for each condition. The only time Captain Flaherty will not be handling post-exposure reporting is if he is out of town. And he has already worked this out with Captain Tim Prince. If Captain Flaherty is out of town, Captain Prince will be the one who is handling post-exposure reporting, and you will be notified of that. So this goes into effect July 1st, 2014. So just be aware of that. In the next few weeks, we're going to be changing to this procedure. I listed here the most common OSHA bloodborne pathogens citations for 2013. We got this from the Catherine West update a few weeks ago as well. Some of those are not having a compliant exposure control plan, not updating that plan annually. There's no initial or annual training. Bloodborne pathogens training is not offered within a year of the previous training. Some Hep B vaccines, they're not offered in the time frame. There hasn't been declination forms filled out. So some different citations there, which We are working to not have any violations. We need your help with this as well. So those are here. The CDC and OSHA, I'm sorry, not CDC, the OSHA's website also lists these as well for common citations, so you can find more information there if you are interested. These next few slides I have included. The CDC has recommendations for, or not recommendations, guidelines for work restriction. So if you have a certain disease or condition, they have work restriction guidelines for that, how long the work restriction is to be in place, and they have categories listed there as well. So these slides are more for your information. If you want to take a few minutes and look over those, you'll see the link at the bottom as well where I found these. So these are other conditions here, and again, what the condition is. Some of them are listing whether they're chronic or acute. Some of these have no recommendation for work restriction, and some of them do have work restriction. And especially on this slide, you'll see there are specific time frames for those work restrictions. So at the bottom, you'll see with pertussis, with whooping cough, are they asymptomatic or are they symptomatic? Because that's going to make a difference in what their work restriction is. So some of these are until lesions have been removed. Some of these are a daytime frame. So if you need more information about this, you can follow this link. The bottom there is the article where I got this. I know the reference is 1998, but that is the most up-to-date information that the website has. So that link will take you straight to the CDC, straight to that article. And if you have any questions, I would be more than happy to answer them for you, which gets me to the next slide of if you have any questions regarding this, you are to call and speak with us in person. Do not send an email. Make sure that you talk with one of the following people. So you can call me. You can call Captain Crystal Leffler as well. My phone number is listed there, 843-915-7051. Captain Leffler's phone number is listed there, 843-915-7062. So we are available Monday to Friday, 8 to 5. If you leave a voicemail, we will get back to you as soon as we can, but we need to talk to you over the phone or in person. For evenings and weekends, if you're watching this and it's not office hours, you can contact Captain Tony Flaherty. His phone number is 843-446-6610. So make sure you contact any of us, make sure you talk to us, and please remind your fellow coworkers that this assignment needs to be completed no later than Thursday, June 26th, 2014 at 5 p.m. So in addition to watching this video, you have a quiz that you need to take, and ALS providers have a SHARPS survey that you need to do as well. So please make sure you are getting this completed on time, and please contact us if you have any questions, and we will give you further information as we get it, and we will see you next year for next year's annual Bloodborne Pathogens update. Thank you very much, and we will talk with you guys later.